Hello, everybody. Good afternoon, good evening, good morning, wherever you're tuning in from. Welcome to Neurology for Vets, the Facebook site. Free neurology webinar series going on this week. This is day 4 of 7 in aid of the children affected by the Ukraine crisis. Thank you for everyone tuning in, for giving up your time, and to all the speakers, especially our speaker today, Ines Carrera. All speakers are giving up their time for free, and their expertise, obviously, too. Please remember to donate if you already haven't done so. There will be a secure link provided in the chat section. Now, so far, there's been £7,300 raised. That's nearly $10,000, over €8,000, which is fantastic, but we're expecting more, really only halfway through here. So keep on going, however small. Please consider donating to this really worthy cause. Today, we are very happy, proud to have Ines Carrera as our speaker, particularly so because today being International Women's Day. Thank you to all women in the veterinary profession. Obviously, without you, the profession would be nothing. So this day honors you. Fantastic. And Ines here to represent you all. And today she's going to be talking about ring enhancing lesions in the brain on MRI. Now, most of you are already going to know Ines, but today just a brief introduction for she did a diagnostic imaging residency at the University of Glasgow, and from the beginning was really focused on neuroimaging. She is a board certified radiologist, imager, and has worked in several universities, including Illinois in the USA, Sydney in Australia, and Zurich in Switzerland. She's done a PhD in MR spectroscopy of the brain in dogs while she was at University of Bern in Zurich. And currently she's working as part of the neuroimaging team at Vet Oracle Teleradiology. So welcome, Ines. A great honor again to have you on. Thank you very much.
Thank you so much, Simon, for this introduction. And before we start the lecture, I would like to say 2 things. First, thank you, Logan, for this initiative, because it's just something that I find really nice to do, because in these horrible times that we gave peace for granted, now we see all this suffering and we feel really frustrated. At least with this, we hope to be able to help somebody. And this is just really nice from you. And I thank you a lot to allow me to do my little part. So thanks a lot.
You're very welcome.
And so please, as Simon say, if you can donate, even if it's just a little bit, it's gonna. We hope that it's gonna help many people. So please do. And the second thing, also thank you, Logan, because this lecture was his idea, and even the title. Now that I'm not that bright and for the titles.
I'm a big Beyonce fan, that's why.
So even he suggested that they put a ring on it. Is a song of Beyonce. So now I was wondering if maybe this is the song that you want Simon to sing.
Yeah.
This is okay.
If I have to sing that, the price has just gone up to £10,000.
All right, I put the link. Go for it.
So now I leave you sing and dance, and I'll just give the talk, okay?
Okay, perfect.
It's happy to go. You want me to bring the presentation?
Yes, please.
And I remove us.
Yes, we are going to talk about ring enhancing lesions. And I gathered quite a few nice cases for you with a rim enhanced appearance in post-contrast images. I'm going to go through most of them. And we will understand the different patterns. But before we do this, I would like to remind the mechanisms of contrast enhancement in the CNS. In the contrast enhancement in the CNS is a combination of intravascular enhancement and interstitial extravascular enhancement. And what is very important and unique of the CNS is the blood-brain barrier, which is an endothelial cell specialization that blocks lipophilic compounds and creates a unique interstitial fluid environment for neural tissues. So after bolus injection, normally it's gadolinium, it creates a gradient across the capillary endothelial membrane, and because in normal conditions there is not going to be any enhancement or any contrast within the interstitial or extravascular tissues. When there is an interstitial enhancement, is related to alterations in the permeability of the blood-brain barrier, and when there is an increase of the intravascular enhancement, is related to vasodilation or neovascularization that happens in many pathologies. So now I just do a summary of the contrast enhancement patterns, and I follow this paper here. Radiographics is a review of human medicine, but I found it really nice. And as you see, they have these are the drawings from this paper. So I found them really nice and very illustrative. So the extraaxial enhancement can be divided into pachymeningeal or dura arachnoid. This one including the typical enhancement of a meningioma with the dural tail. And the leptomeningeal enhancement is the one that extends into the sulci. Intraaxial enhancement. So this contrast enhancement pattern is mainly focused on the location of the enhancement. So the intraaxial is the gyral enhancement, when it's the cortex, the gray matter enhanced. This happens mainly in infarcts. Nodular, cortical or subcortical enhancement. In people, they define very nicely the location between subcortical and cortical, because some lesions, they tend to have the specific locations, and they define that metastases normally are nodular cortical, and other neoplasias are deeper or subcortical. And then there is also the periventricular enhancement. And then lastly, and this is the one that we are going to go through today, is the ring enhancement. So as you see here, they define different ring enhancement. This one here that is got a thick wall, but is quite nice, smooth, and rather even. This one here that is very irregular, uneven, with quite thick walls, and this one here that is got a very thin and very well defined wall. And these walls, they are going to enhance after contrast, and this is what we are going to define or describe as ring enhancement. So now I come back to, no, sorry, I forgot. So what are the lesions, the pathologies more common that they can have a pattern of rim enhancement? So the most common are the abscesses. They can be bacterial or fungal more commonly, and necrotic neoplasias. And the necrotic neoplasias are normally, they are high-grade neoplasias, and they can be primary as gliomas or metastatic. And then there are also cystic lesions that can have a rim enhancement, that they can be fluid-secreting neoplasias or benign lesions like epidermoid cysts, subarachnoid cysts, rhabdoid cyst. So now I come back to this first image, and we are gonna go through the first one, that is this one, which was an abscess, an intracranial abscess. So the ring enhancement in an abscess reflects the granulation tissue in its wall that has both increased vascularity and abnormal permeably capillaries. So there are more vessels than normal, and the permeability of them is quite abnormal. So the blood-brain barrier is disrupted, and that's why they enhance quite a lot. There is collagen in the wall of the abscess, which reinforces the localized or focalized infection. The organizing infection and the wall has concentric zone layers. This picture is also from the review article that I showed you before. So the most inner part is the necrotic brain, followed by reactive white cells and fibroblasts, and then followed by capillary vascular proliferation and collagen capsule. Then in the more outer part, there is neovascularization and active cerebritis, and reactive astrogliosis and vasogenic edema, because all abscesses, they always have a lot of perilesional edema and quite a lot of mass effect. They look quite aggressive to the brain. So the signal intensity pattern of the abscesses. So as now, if we compare to the drawing that I showed you at the beginning, you see that the abscess has a quite uniform, convex and smooth wall in both the outer and the inner part of them. So it's a nice, thick and complete smooth ring. If we look at the abscess in the other sequences, it's got a hypo-intense rim in T2 and a hyper-intense center in T2. And this probably is because of the amount of collagen and in the wall, and in the center because of the necrosis. You see that necrosis is hyper-intense in T2, but because it's not pure fluid, it's pus that is really thick, it's not going to suppress in flare. It's going to keep rather hyper-intense. So we can distinguish that from a cystic lesion. In diffusion weighting and ADC, the abscesses normally are quite characteristic because the rim is hypo-intense in diffusion, and while the center is hyper-intense, and in ADC the ADC map is opposite. The rim is hyper-intense and the center is hypo-intense, which means that the center is restrictive, it's got a restricted diffusion, and the wall has a facilitated diffusion. This is because of the increased vascularization, and the center because of the necrosis. So this was has been recently described in this publication in Vet Radiology, which is quite characteristic of abscesses, to have a restricted center, restricted diffusion. However, just put this paper from Human Medicine is not pathognomonic from a brain abscess. There may be some overlap, and also there is some overlap of the restriction of facilitated diffusion in neoplasia. So it's something that sometimes it can help us when it's that beautiful and like the one that I'm showing you right now, but is again is not pathognomonic. I'm not going to go through the causes of each pathology, but abscesses normally, or either they are hematogenous or they are secondary of a previous trauma or open injury or a contiguous infection. So we always have to correlate everything. We don't read one image, we read the whole of the case, right? If we look more at these post-contrast images, plus all the sequences that I show you, we have no doubts that it's going to be an abscess, because we also see a fracture in the skull here, in the temporal bone, and also we see meningeal enhancement with some splitting of the layers here that indicates an empyema. So this is not going to happen with a neoplasia. So there are things, when it's very challenging is when it's a hematogenous abscess and we don't have anything, any other associated abnormalities. So then is when it's more difficult to differentiate an abscess from a necrotic neoplasia. So now I continue with the next group, and this is going to be the neoplasias. So the necrotic tumors are malignant of high grade, and they can be, as I said before, primary or metastatic neoplasia. They normally have a thick and irregular wall with a shaggy or very irregular inner margin, and they can also be multilocular and with complex rim patterns. It's quite frequent in glioblastomas multiformes that are probably the most malignant gliomastrocytoma, and they enhance because the rim contains a lot of new vessels, neovascularization with very abnormal blood-brain barrier, because these tumors are quite aggressive and they disrupt very easily the blood-brain barrier. I read that in humans, I'm not aware that there is any study in people, in dogs or cats, but I found this very interesting, that in delayed post-contrast images in high-grade neoplasias, when they have a rim enhancement, there is a progressive enhancement inside the rim, usually patchy, and this reflects islands of the tumor, so remnants of or little pieces of the tumor inside the necrotic center. So this is the other sequences of the first neoplasia that I want to show you. You see that it's quite similar, this rim enhancement, to the diagram. So it's got a very uneven and irregular wall that is even more irregular in the inner margin than the outer margin. So it's different if we now compare with the abscess. Very interesting, if we look now in the susceptibility weighting image, that this susceptibility weighting is a sequence that allows us to look for hemorrhage, but also for neovascularization. which is probably the only one that we can do that in MRI. So here we see how nice we see all these tiny tubular signal void lesions that they represent neovascularization. So probably if this dog we will have done a delay post-contrast, probably all this area here central that will enhance more. Now we see on the bottom images diffusion weighting and ADC, and then you see that this lesion has a mixed pattern of hypo and hyper, but this is rather hypo intense in ADC, so it's got a degree of restriction of the diffusion. On the T2 and on the flare, you see that it's got a rather hyper intense rim in flare and T2, and the center is heterogeneous of mixed signal intensity. The next one is again very irregular. It's more irregular in the inner aspect than on in the periphery. And then you see that there is a center of the lesion that is enhancing. And if we look in the susceptibility weighting, we see these little tiny vessels that they correspond exactly where the enhancement is. So it's quite nice, this correlation of the neovascularization with enhancement. You see that in the T2, this lesion is also rather hyperintense, and the rim is also hyperintense, as well as in flare, and the center is a bit more heterogeneous, a bit more hyper and hypointense, reflecting this necrosis. And in ADC map, you see again that it's got a mix between hyper and hypointensity, so it's got a mix between restricted diffusion and facilitated diffusion. And now this is a video of a cat. These are the T1 post-contrast images, and you will see, I think you saw one, now we are seeing another one and another one. So I'm gonna play it again. So there are multiple well-defined, rounded, rim enhancing space occupying lesions in patchy distribution, and the biggest one is in the area of the vermis of the cerebellum. So if we look at this, the biggest lesion is quite nice. This one is a bit smoother than the other two ones, but you see that the inner aspect is also quite irregular. And there is an area in the center that is enhancing. And in the T2 star, here we don't have susceptibility, it's just T2 star. We don't see any evidence of signal void, so there is no evidence of intralesional hemorrhage. In the T2, this lesion is quite ill-defined. We don't see the borders very nicely, and the center is slightly more hypo-intense, and the same happens in flare. So now I want to just, I like the title of this paper. It's from Human Medicine. The pattern of the T2 hypointensity associated with rim enhancing brain lesions can help to differentiate pathology. And I find that just the title is super useful. So if we keep this in mind, we come back to these examples that we have seen. So the abscess had a really nice hypo-intense rim in T2, while the neoplasias, none of them have a hypo-intense rim. They just have a hyper-intense rim. But all of them, as I explained you, we saw on the susceptibility weighting in the two first ones that they have little vessels, but none of them have hemorrhage. And the metastasis in the cat didn't have a hemorrhage either. They have necrosis, but no hemorrhages in this case. So now, just keeping that in mind, I'm just gonna continue with these two cases, and we are gonna compare them. So I put first the T1 post-contrast and the T2. So this is a lesion. I'm gonna just explain the one on the top of the images, and we see a quite well-defined oval space occupying lesion intraaxial that is got a peripheral thin, slightly irregular rim enhancement. So this is slightly different from the ones that we saw. So this is not that thick one that we saw with the abscess and smooth and that irregular as we saw before. But we can call it a rim because it's rounded. On the T2, we can see that there is a nice rim of hypointensity in T2, while the center is nicely hyper-intense. If we now look at the one at the bottom, we see that this lesion also has a peripheral rim enhancement, slightly uneven because on the ventral aspect is enhancing a little bit more. But we also see that there is an area in the ventral aspect of the lesion, within the lesion, that is enhancing. On the T2, we can see that this lesion has a hypo-intense rim. But you see, if we follow this one, if we trace a line, it's continuous. But if we follow a line like this, in this one, it's not continuous here. So we are gonna just, whenever we want to see this, we also look in other planes to confirm. So on the dorsal T2, if I trace a line around this lesion, the hypointense rim is complete. But if I do the same in this one, it's not complete. It's a bit around, but it's not complete. If now I keep comparing these two cases, and now I have the T1 post-contrast that we saw before, now the T1 pre-contrast and the T2 star, and the susceptibility weighting on the one in the bottom. So in the T1, we see that there is a very thin, but there is a thin, very thin hypo-intense rim, and just inwards and adjacent to that, there is a thin and nice hyper-intense area in T1 pre-contrast. And then on the T2, what we see is a thick, much thicker signal void rim. And then if we compare the T1 and the T1 post-contrast, we see that the enhancement is only around the lesion, in the periphery, but nothing inside the lesion. If now we compare or we look at the one in the bottom of the images, we see that there is no complete hypointense rim in the T1, and I cannot see either any hyperintense area surrounding the periphery. There is an area that is slightly like iso-intense to white matter, and this is the one that is enhancing after contrast. If we look at this and the susceptibility weighting, the center of the lesion is got a lot of signal void, so that means that there is a quite disorganized, very untidy hemorrhage. So both of these lesions, they look hemorrhagic, but they are different. If we now kind of summarize this, the first one had a complete hypointense rim, a peripheral rim enhancement, and dichotomous untidy appearance of the lesion in all sequences. And if we want to work out the timing of the hemorrhage, we can do it. I'll come back to that. While the second one, there is an incomplete hypointense T2 rim, peripheral and central contrast enhancement, and a heterogeneous pattern without an expected timing of the hemoglobin degradation. If I come back here, so why we see this in T1 and in T2 star? So this outer rim is the oldest area of a hemorrhage, and it can be compatible with hemosiderin. The hyperintense area here is in T1. It fits with meta-hemoglobin extracellular, and that's why it's got a shortening in the T1. And that's why we also see the rim in T2 star thicker. The central area of this lesion, it must be either meta-hemoglobin intracellular or desoxyhemoglobin, which are not paramagnetic, are diamagnetic, so they don't cause any shortening in T1 and neither on the T2 star. So this fits very nicely. But in this one, if we try to do the same, it's just not possible. So this was, the two of them were confirmed. This one, it was a hematoma, and this one was a hemangioma. So these are two lesions that they have a rim enhancement, but one is a benign hemorrhagic lesion, a hematoma, and the other one is a hemorrhagic tumor. In this case, it's different as the other tumors that I explained before. This is not necrotic tumor. This was a hemorrhagic tumor. If you want to read more about hematomas, James Whitlock just published this really nice paper, and I'm sure many of you saw his presentation less than a month ago. And now I continue with fluid secreting neoplasias. So there are some neoplasias that normally are low grade, that they secrete fluid and they form cystic lesions. Is distinct, is different from necrosis. It's just a cystic lesion within the lesion or in the periphery of the lesion. In people, they are quite well described in pilocytic astrocytomas that are very common in the cerebellum, and hemangioblastomas. That they are very beautiful neoplasias. Like this one is in the diagram is the most typical aspect of a hemangioblastoma, but it's not very common at all in dogs and in cats. So probably the most common one is meningioma, or others that may not be perhaps that benign, but they still have some cystic components. I'll show you the examples of those. Sometimes the rim of the cystic areas is quite thin, and it may not enhance, or it may look quite discontinuous, but this can be due because of compression of the lesion or because of gliotic tissue surrounding it. So this is an example of two examples, sorry, of area. This dog at the top with this lesion in the cerebropontine area. I don't know the final diagnosis, I'm sorry, but I put this example anyway because we see that there is a nice solid area that it looks very much like a hemangioblastoma, like in the diagram that I show you, with a central solid portion surrounded by a nice cystic component. So maybe this is a hemangioblastoma that I'm looking for, that I haven't seen yet confirmed. So perhaps. And this one is a very large cystic lesion of a tumor that was centered in the cribriform plate. It looked very much like a olfactory neuroblastoma. And this is a quite nice, impressive meningioma. Confirmed, and so this we have here the cystic lesion, excuse me, the solid portion, quite nicely, typically enhanced, with some motile appearance in T2 that might represent mineralization, and in this case has a very large cystic lesion that is actually kind of outside the mass. It's more common in meningiomas to have the cystic lesion within the cystic area within the cystic lesion, excuse me. It's more common for meningiomas to have the cystic area within the mass itself, but this is very uncommon, but it can also happen that is kind of outside the solid portion. So now I'm just almost finishing, just to show you other examples of very thin rim enhancement in benign lesions. Like this is a subarachnoid diverticulum. That is a case that we discussed a while ago in another Facebook Live discussion, and this is a really nice case that Laurent gave me today of an epidermoid cyst. And you see this beautiful also rim enhancement that is slightly thicker than on a subarachnoid diverticulum. And also you see that the signal intensity is different from a diverticulum. A diverticulum is iso-intense to CSF. And this one you see that is quite hyper-intense in T2, but it doesn't suppress in flare. It keeps hyper-intense. And they are described that it's possible to be hyper-intense in T1, but they can also be iso to hypo. So this is me for today. This is what I did for you. So I hope you enjoy it. And I thank you very much for being there. Thank you very, very much for supporting Ukraine.
Thank you very much, Ines. I was really looking forward to the presentation, and I haven't been disappointed. I think I need to stress to everyone that I suggested that talk to Ines on Friday morning, and what you see there is something that she has put together in the space of the weekend, because it was ready, by Monday, and she said, "Oh, can you have a look with me?" and so on. So, I think for anyone else like us, it would have taken weeks to actually put that together. Never thought that it was done in a couple of days. So,
I had a lot of fun doing it.
I have to say that you've well earned the title I've given you of the Queen of Neuroimaging. You own the crown.
Yeah, you give me more titles like this to do more talks like this, please. Thank you.
If you have any questions, please put them in the chat box. There is one question so far from Bea. Ines, in your experience, have you seen differences in the appearance of brain abscesses depending on the chronicity?
Yes, because the abscess is the kind of the end stage of the infection, because before is the cerebritis and the early capsule formation and the late capsule formation. So in earlier infections in the brain, we may not see a rim. And what I don't know, if maybe if you are meaning the mature abscess, if they have different appearance over time, this I don't know. I guess they don't. My guess that will be that they don't change that much.
And there's another question I'm just going to ask you. The degree of perilesional edema, can it help to differentiate all these ring-enhancing lesions? So you say the abscess, they will have a lot, but I presume with time, as it become more mature, will the edema reduce as well? And
no, I think they all have, because they are all quite aggressive lesions, both the necrotic neoplasias or abscesses. So they all have a lot of perilesional edema. And if it's an abscess that the antibiotics are not working or is not being treated, is never going to resolve. The only case that is going to resolve the perilesional edema is in a haematoma.
Okay.
Because the hematoma is going to shrink, or most of them, over time. So then, because it decreases the size, then the perilesional edema is going to decrease. Abscesses and neoplasias, they are not gonna improve by themselves. So therefore, the edema is always going to be there, or even worse.
But particularly like, the drawing, and it's something that I've never read anywhere, the type of the ring enhancement, and whether or not it's quite neat or irregular in the inner border. I think it's very useful, really, really good. And as you said, the T2 hypointensity, it really showed a difference between all of them, definitely. If you have any more questions, please feel free to ask them.
Can I say something? It's because Bea, hola, is a very good friend of mine. And do you see that picture on the wall of this beautiful, beautiful fruits with MRI? She gave it she did it for me. Now you're famous, Bea.
I see if you reply. No, I think she's too shy to reply. One from Ricardo. How to differentiate abscesses from neoplasia that have water diffusion restriction?
I think we cannot, as this human paper said, there is no way of, it's not pathognomonic, so we cannot differentiate them. The only imaging model or technique or sequence that will be pathognomonic, that will be spectroscopy at 3 Tesla.
Okay.
And that can even tell anaerobic abscesses from aerobic abscesses. It's quite impressive.
Wow.
I had one case in Zurich of an abscess in a goat, and I could see the metabolites that they were anaerobic, and that was proven. I don't remember the agent. There is a case report written, but yes, it's the only modality that can be pathognomonic. But having said that, again, it has to be above 3 Tesla, because 1.5 Tesla cannot detect those metabolites because they are too small.
Ricardo say thank you, and just be prepared to blush. Bea say I did it because she is the best. Best teacher and mentor. Any more question for Ines while she start to cool down a bit because she blushed? If we don't have any more questions, I just wanted to all let you know what is the plan for tomorrow. Let me find the banner quickly. Tomorrow we got another fantastic speaker. We got Claire Rusbridge that will talk to us about the minefield of this wobbler syndrome in terms of agreeing on what is Wobbler syndrome, so pathophysiology, diagnosis, and let alone treatment. I spoke to Claire before this presentation, and Claire will be broadcasting from the lecture theater of Fitzpatrick Referral. So she will have some students and staff from Fitz, with her in the lecture theater. So I can guarantee you it's going to be very entertaining and also very enlightening presentation. Claire is also a fantastic speaker, and I'm very grateful for her to join us in this fundraising effort. If you can donate and you haven't done so, please, any small or big donation is welcome. It will go for a good cause. I wanted to thanks again Ines. I don't think I will have, put this program without her. There was no way. She has to be there, and she responded to the call, straight away. And I'm very grateful. Simon, my old friend, always, there with us.
Thank you, Ines, for just a phenomenal presentation. That really was great, and thanks, obviously, Laurent, for keeping on pushing through and hosting this. A great initiative, and for everyone out there, again, thanks for giving up your time to listen. This has been another fantastic session, and we hope that will inspire you to donate to this terrible crisis. And remember, the vet profession stands with you, and hopefully you'll tune in again tomorrow to see another great presentation.
Thank you. Have a good night. Thanks, Ines.
Thank you. Bye.
Thank you. Bye.